Hello and welcome to this specialized webinar titled Dimensions, Building Community Trust Through Peers and Lay Providers. Today we're going to extend our discussion from the masterclass and focus on peers and lay providers and how to implement peer-driven programming. I'll be using the term peer throughout this presentation, but do note that the lay providers term can be appropriate as well. So my name is Derek Noland and have the pleasure of meeting many of you. I am a community liaison at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus, where part of my role is to help a variety of agencies to implement tobacco services and policies. I also have a background in global public health and tobacco research, and I had the experience of managing a 3-year peer-driven project for BHWP that was sponsored by the Colorado Department of Public Health and Environment. And we'll return to this later in the presentation. So my goal for today is to provide an overview of how to implement peer-driven programs and thereby reach a wider audience of clients in order to support their tobacco cessation goals. So more specifically, I will begin by providing a brief overview of the recovery movement and peer-driven programming in general, including considerations of why to hire peer specialists and where and how to place them in different types of professional settings. I will then describe in some detail 3 different diverse peer programs that BHWP has conducted over the last few years, sharing some of the key outcomes and takeaways from those programs, as well as practical guidance for sustainable peer services and programs in general. And finally, I'll close by considering some of the challenges and rewards of peer work and some practical considerations for how to successfully implement peer services. I hope that upon completing this webinar, you'll feel inspired to consider implementing peer services at your agency and will attain some practical next steps to actually help you get started. But first, let's begin at the start with an overview of peer-driven programming and considerations about why and how this work can be so valuable and rewarding not just to the people that the peers serve, but also to the peers themselves and to agencies at large as well. So I want to start by reading this definition of peer support or of the peer position. So a peer provider is a person who uses his or her lived experience plus skills learned in formal training to deliver services in health and public health settings to promote mind-body recovery and resiliency. So there's a few things to unpack here, and really the key point that I want to highlight is the lived experience context here. So that's very important to the peer role and really defines the peer role. It's paramount to the peer role. These are individuals who may have lived experience with substance use conditions, perhaps, as we'll see in one of our projects, perhaps lived experience being homeless. They may have lived experience within a certain community or group as well. And these experiences really are valuable when rendered appropriately. But the addition of formal skills and training is very important too in order to deliver these skills in a successful way and to be able to help people, particularly when we think about the tobacco cessation standpoint. So a bit about recovery and peer specialists. So over the past decade, this concept of recovery has gained increased traction within the healthcare industry and social service settings and also the criminal justice system. And SAMHSA defines discovery as such, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their fullest potential. So organizations within these industries have evolved their focus to include recovery, resiliency, and self-management. And this approach has really been incorporated into treating a range of different chronic physical and behavioral health conditions, including substance use and tobacco use. This shift highlights the roles that individuals play in their own recovery and the role of peers. So as you can see here on the slide, peer specialists are people who are trained to use their personal recovery experiences to help guide, inspire, advocate for, and empower others who are not as far along in their own recovery. So a very similar definition to the peer one that we saw in the previous slide. I want to point out that these lived experiences may include chronic physical or mental health conditions, and as I've mentioned already, it could be substance abuse or homelessness, It also may be involvement in the criminal justice system, and in a number of different community settings as well. And due to these lived experiences, peers do possess a unique skill set that can be leveraged to connect marginalized populations to social services, resources, healthcare, and other different services that they may benefit from. So why hire peer specialists? Well, we do know from the scientific literature, in fact, that peer support programs are very effective. Research has demonstrated positive effects for both program participants, but also for the peer specialists themselves. In fact, peer specialists have been shown to be equally as effective as other healthcare providers at stabilizing clients, and perhaps are even more effective at engaging clients who may be mistrustful or not involved in the healthcare system. And that really is one of the fundamental keys of the peer specialist. So let's kind of look at the two lists on the slide here. I'll start with the left. Some of the benefits of working with a peer specialist. So this would be from the client perspective primarily. The clients generally do experience increased engagement and activation and treatment when they work with a peer specialist. So as you can see, they're more likely just to initiate some sort of service in general. They experience increased empowerment and hope. And some of that is from seeing, as peer specialists who is far along in their recovery and in a position to help them. They experience increased life satisfaction and quality, as you would suspect if they're being routed to services. They do experience decreased self-stigma, so less of that negative self-reflection. You see reduced use of inpatient services. So basically, we're able to reach people before that might be necessary. So there's some prevention in place here. We see increased social functioning, increased community engagement. So people feel inspired and motivated to become a fuller part of their community. And we do see decreased hospitalization as well. So another great feature there tied to prevention and helping people to, prevent that from the start. And so to look at the right side, here are some of the benefits of working as a peer specialist. So for that peer specialist themselves, increased knowledge, of course, if they're working in a different environment, they're learning about that environment and how to thrive there. They do experience an increased sense of empowerment and self-worth through the work that they're able to do and the services that they're able to provide, which leads to a general improved quality of life. And it does lead to increased stabilization and resilience. So, peers who work as peer specialists are generally do become more stable and resilient and continue in their recovery. And of course, they may also experience increased financial independence and less reliance on benefits. So altogether, the body of evidence here strongly does support the value of peer work, both for the people they serve and again, for the peers themselves. And naturally, these benefits also extend to the organizations who hire and support peer work. For a moment, let's look more specifically at the topic of building community trust. Peers can be ideally situated to do just that, particularly when they are working within their own community. And that's because as members of the community, peers understand the unique challenges that their clients face. In fact, they typically understand those challenges better than perhaps a highly trained healthcare professional or someone of that nature. Moreover, peers are often more familiar with valuable local resources or have the ability to identify and ascertain those resources due to their placement within that community. In this context, peers are able to make even greater inroads as they will naturally use relatable language and expressions, and may also share perhaps a common physical appearance as well as similar ethnic, racial, and or cultural backgrounds with the clients that they serve. And so in this manner, they can effectively connect agencies to communities that might otherwise shy away from services. And finally, it's worth noting that when peers work within their own communities in particular, they're natural stakeholders in the outcomes they're pursuing, which can amplify their work even further. Okay, we know that individuals with overlapping vulnerabilities and risk factors have complex needs, And we also know that these concerns are often undermanaged and simply not adequately treated within healthcare systems that, tend to be highly fragmented. And so when we think about priority populations, different vulnerable or disadvantaged groups, kind of as we discussed in the masterclass, all of these priority populations face stigma, implicit and explicit biases from members of the community and service providers, and just other, disadvantages due to their status. And as a result, these individuals may be mistrusting of healthcare and avoid those services. And, in many cases for good reason. However, they therefore face greater challenges in procuring health and may face worse healthcare outcomes as a result. However, when services are positioned where people are more likely to access them, some of these disadvantages or hesitations can be overcome. So in the patient-centered medical neighborhood model, any point of service or intervention can become a hub of care, including outside of the medical context. And often that is what we're talking about in this model. And these access points may represent a broad range of different types of providers. So to take this concept a bit further, we can consider the health neighborhood model, as you can see on this slide, in which any point of service can become the hub of care. And so this structure is designed to meet priority populations in whatever setting they access, whether it be, as you can see here, perhaps within the judicial system, at community mental health centers, reentry or law enforcement programs. It could be at primary care, substance abuse treatment settings, benefits acquisitions, pharmacy, public health, state and local housing authorities. So just some of the different places that can constitute a health neighborhood. And in this way, we can extend our reach to a much larger swath of a population. Furthermore, when people are accessing services at these settings, they're more likely to be trusting of them and therefore more willing to engage. And to relate this back to tobacco cessation, all of these types of settings can be empowered to perform basic tobacco use screening and referral. So, perhaps the two A's and an R, ask, advise, and refer. And these referrals in turn are more likely to be trusted. And ideally, some of these settings will offer cessation services directly, actually, and thereby could create a one-stop shop for individuals from priority populations. And while that would be the gold standard or the ultimate target, just having even basic screening and referral really is important and really can make a big difference. Okay, so with that background in place about peer specialists and about leveraging these services, let's now look at three different programs that BHWP has conducted in recent years. These three examples provide real-world samples of the variety of ways in which peer services can be utilized, and they also reveal the value and power of this type of intervention. And we'll see differences between the three and be able to pick out some of the things that are particularly valuable in these types of projects. So in our first project, peer support specialists were actually embedded at the Denver Public Library in order to support and extend some of the existing social services there and really to extend them to a level that had not existed before. And the project ultimately sought to also evaluate peer efficacy within this setting, which is clearly not a traditional setting for healthcare services, and so could be considered another one of the hubs of care in that health neighborhood model that we looked at a moment ago. Okay, so the It Takes a Library project, as it was called, really stemmed from a pressing need that the Denver Public Library and its staff were experiencing. There was a great increase in homelessness in Denver around this time and in the downtown Denver area. This was a few years ago. And the library had increasingly become a safe space, a public refuge, if you will. However, library personnel were thus increasingly being called upon to answer questions about resources and access to services and things that just that they weren't necessarily equipped to answer or well positioned to help. And you can see that quote from the social worker at Denver Public Library. So this is someone involved in the project. Librarians really want to help people, but when the questions are, how do I get to substance treatment? and they just don't have, the librarians just don't have that information, it's hard. So just kind of a real world look at some of the problems that were occurring here. You can see that complicating all these issues is that in addition to the increase in homelessness in the area, opioid overdoses were increasing as well, including within the library. And so this was a great challenge that the library was facing. And security personnel had to spend a lot of time on this. You can see that second point. By the time this project began, the Denver Public Library had already hired 2 social workers and additional security personnel. So they had already started responding to this, this growing concern or demand. And in 2017, 2 grants allowed the library to hire 4 peer support peer specialists, and also to evaluate the outcomes of their work. And really that's the part where BHWP came in to help. Okay, so I want to look at the program design here with just some oversight of how this was structured. And the figure on the right shows the basic structure of the program at the library. So you can see here that peers handled the direct service, the outreach efforts, and drop-in hours. And so that was the primary scope of the work that they did. They did perform outreach in and right outside the library, asking people if they needed assistance, trying to help provide resources. This included bus passes and referrals to different types of services. And over time, they developed relationships with a lot of these individuals who frequented the library, and in turn became even better positioned to help them. Social workers helped the peers, as you can see, with crisis work and of course peer supervision activities, conducting staff trainings to help peers to succeed in their role and to maintain progress and recovery. And then we also had a lead social worker that was sponsored by the Colorado Mental Wellness Network, which is a peer-run organization in Colorado that helped to provide oversight and to organize the project, and did a lot of those administrative tasks, identifying and hiring peers, organizing the staff and the trainings. The Colorado Mental Wellness Network had a lot of trainings at their disposal that they could use, and a lot of great results. We can see a couple quotes from a peer support specialist on the left there. "I got to be the person I needed years ago." So this is a peer being able to kind of pay it forward, if you will. Or, "The way we can help people really adds to my self-esteem and my self-worth and gives me fulfillment and makes me happy." So clearly a lot of value to that individual who's performing this work. Okay, so prior to joining the project, peer support specialists attended an 80-hour training that was offered by the Colorado Mental Wellness Network. And this training it included a number of different topics, including recovery, advocacy for peer moments and advocacy for oneself, ethics, communication skills, a lot of attention on self-care and boundaries, trauma-informed support, resiliency, and really just a wide variety of topics are covered over those 80 hours. And additionally, these trainings and parts of these trainings were made available to other library staff who might be interested in attending them as well, and getting a better understanding of the peer role, and also improving themselves in the process. And so the positions that the peer specialists served were designed as part-time positions, so 20 to 30 hours per week, 30 being the maximum. And that really was not only to prevent burnout among the peers, but also to allow more time for self-care and to make sure that the peers continued forward in their recovery. And so peers were supervised directly by licensed social workers, and the whole team would meet together weekly, and the social workers would meet with peers for an additional 30 minutes per week beyond that. And even in addition to that, peers could meet with staff members from the Colorado Mental Wellness Network for an hour as well. And so one peer actually described this setup as being kind of similar to a support group. So you can see that great professional support was instilled in this project to really help assure that the peers could succeed and continue their recovery. Okay, so at the beginning of the program, we helped the peer support specialists and social workers to implement a detailed tracking system for all the types of customer contexts at the library. We really wanted to be able to evaluate what we were doing. And so we basically had two key goals. We wanted to maintain the privacy and the trust of the customers who use the social services at the library. And we also wanted to collect, adequate information in order to facilitate tracking the volume of contacts and the breadth of the customer needs that were addressed through the project. So we actually did spend several months developing and fine-tuning a system for data collection that we could use to generate useful information for stakeholders, but also to minimize the burden on the peer specialists and the social workers. We really wanted them to be able to focus on, the person-to-person interaction to the extent possible. And so over the course of the project, the quality of the data improved greatly over time. We noticed this. It was very recognizable. And we think this is possibly because peers and social workers became more comfortable with the process, of course, but we also think that the customers themselves may have become increasingly trusting of the staff over time, and we're simply more likely to divulge personal information and to go a little further with their interaction with the peers. So as you can see from some of the stats here, we made nearly 3,000 contacts with customers over this time period. And about 70% of these individuals provided enough information in order to determine if they are one-time or repeat customers. And while we estimate that about 1,600 unique individuals were served, a big chunk of these was the same people. So you can see, while they may have only comprised about 28% of the overall sample, the repeat customers actually accounted for 60% of the total customer contacts. So we think that really points to their trust in the system and their willingness and interest to return for further support. And you can see on the right here a pie chart of the different distribution of services provided. You can see a lot of different types of services there. This breakdown shows that services related to homeless resources and housing support made up a little over 40% of the services. And then in addition, referrals to physical and behavioral health services, including substance abuse treatment, made up roughly another 30% of services. And there were some other smaller categories there, like legal document support and state benefit support and other practical supports like those. Okay, so in wrapping up the discussion of this first project, I do want to also touch on some of the positive impacts that the project had on the library staff, the library as a whole, and really the surrounding community in general. With respect to changing library dynamics, the project really catalyzed a deliberate shift in the library's culture of community. And you can see this quote in the top right from the security manager, which kind of highlights this. It was kind of like the Wild West. We were handcuffing people 4 or 5 times per week, and we set out to change a culture. And so the library was already looking to make change and to change the culture. And, that feels that quote is indicative of an unsustainable setup and not one that was really doing anyone a great service. And so as time went forward, staff now and as the project was going, really began seeing fewer behavioral incidences, fewer overdoses, fewer just causes for concern, and as a result, less need for security involvement. The second bullet point, increasing staff capacity. Really, every branch of the library did benefit from having the peer specialists and the social workers available. It allowed for greater services to those individuals and also freed up the library staff to focus on some of their normal tasks. And you can see that a second quote in the bottom of left from a technology manager, the level of work we're able to do here is so much higher because we have this resources. So it really did uplift everyone. And lastly, the peers did model recovery for the customers at the library, and they served as a reminder to the library staff as well that recovery is possible and that people can and do get better. And this really helped to battle some of the compassion fatigue that library staff might experience when things were a lot more challenging. You can see that final quote in the bottom right from the social worker in the project. The peers role model for the rest of the staff that it's okay to get to know somebody, to humanize people, and that's huge. So all sorts of great developments there. Okay, so that's our first project. Let's now turn to the second project I want to talk about today. Our second project was the Criminal Justice Tobacco Cessation Equity Project, and this sought to provide peer-facilitated tobacco cessation services to incarcerated individuals who are participating in a pre-release program in Arizona. So these were individuals who would shortly be released from incarceration. And the project was implemented in partnership with the Department of Corrections in Arizona and was funded by the Arizona Department of Public Health and Human Services. So a lot of support from that perspective. And this project was part of a series of efforts to increase cessation services within the justice-involved population in Arizona. And there's more information on kind of the wider scope of this larger project on our website. Today, I'm going to focus on this particular piece of the project, if you will. So let's consider the project rationale and overview. In the United States, the smoking rate among incarcerated people is roughly 3 times higher than it is in the general population. But yet we do know, and research shows, that most of these people do have a desire to quit, and moreover, they can quit with robust cessation treatment. And so the project goal, as you can see here, was to implement and evaluate peer-led cessation services for an extremely underserved population of incarcerated individuals. And the cessation program was implemented at the Eagle Point Second Choice Center in the Department of Corrections in Arizona. And I mentioned this, but this pre-release program aimed to provide skills and resources necessary for reentry into society. So really trying to set these people up for success when they reentered society and avoid recidivism and things of that nature as well. And inmates were selected from this program. Well, the inmates who were selected for the program had about 12 weeks remaining on their sentence. And so that time frame was identified as the right spot to do this. And those pie charts on the left kind of show the disparity between tobacco use in the general population versus in the criminal justice population, where it's significantly higher, as you can see. Okay, so the Dimensions Tobacco-Free program was used for this project. We evaluated the success of the program, which is a flexible 6-session program, which in this case was actually tailored to a justice-involved population. Peer support specialists were actually those who were trained to facilitate the Dimensions curriculum to their peers in that setting. And so the peer educators really were a natural fit for this work. This project does use a train the trainer model so that they were able to in turn train their other peers also to run the group and to support the program and really to help continue the program at the organization. And so 3 different groups got up and running essentially in early 2020. And another critical piece of this is that nicotine replacement therapy was provided by the Arizona Department of Health Services to support the group, and that was starting in the 4th session. You can see there were 6 sessions of 60, 90 minutes each, and we did have some flexibility in the formatting. Some of the groups were run at a quicker rate than others. To return to the nicotine replacement therapy, almost everyone did choose to use that feature. And also that final bullet point there, I'll call that out. BHWP's developed a personal progress form to accompany the Dimensions Tobacco-Free program. And so this form is used at the beginning of each group session in order to monitor and track individual progress over the course of the group. And so again, it's distributed at the start of every session. It's a self-reported form, and that really was the basis for a lot of the data that we gathered that I'm going to present in a moment. Okay, so how did people do in the project? Let's look at, again, these self-reported quit rates as ascertained from the personal progress forms. You can see there were a total of 37 people participating across the 3 groups, and these were all men, to be clear, with almost everyone in this instance reporting using cigarettes, and about 1/3 of them also reporting using chewing tobacco. And so out of these 37 individuals, 9 of them were able to successfully quit tobacco use by the end of the 6-week group. So a very encouraging 24% quit rate there. So individuals were counted as having quit if they reported no tobacco or nicotine use in the preceding 7 days before they answered that question. So of those who did quit, none reported relapsing before the end of the group. But unfortunately, we don't have data beyond that point. So we can't really speculate further on how long these quit attempts were sustained. But at any rate, a very good success rate with this population. Okay, let's look at some more results. Since not everyone was able to quit, we also wanted to have other things to measure. So we wanted to look to see if the amount of their tobacco use decreased over time, and we found that it did. So the orange bars that you can see here indicate the percentage of people who are endorsing the different frequencies of tobacco use we have here. And that would be, during session 1. Whereas the green bars show people's placement in these different categories during session 6. So the first session represented by the orange bars and the last session represented by the green bars. And so you can see that the median number of cigarettes decreased significantly from that 11 to 20 per day category all the way down to the 1 to 5 per day category by the end of session 6. So great movement in that respect. And we also looked to see whether or not attending fewer group sessions would lead to similar reductions. And in this instance, we found that even only attending 2 sessions was actually enough to significantly decrease tobacco use prior to the 3rd session. So again, a lot of positive results there. And finally, we also wanted to see if participants reported a stronger desire to live tobacco-free, live a tobacco-free life following their release. We wanted to see how this changed over the course of the program. And so we compared their responses across these 5 items. You can see have the knowledge to live tobacco-free, plan to take steps to do so, motivated to do so, confident in one's ability, and will have the support needed. And once again, you can see that the averages of the participants increased significantly from session 1 to session 6, with the exception of that motivated category where people were already highly motivated and yet even became more highly motivated. And so these responses were based on the 31 people who completed all 6 sessions. And as you can see, we're very positive, and people did feel in general ready to live a tobacco-free life as indicated by these responses. Okay, so for our final kind of case study here, let's review the Collective Impact Project. And so this project was actually the one that I was the grant manager for at BHWP. And this was also the one that I talked about during our breakout rooms during the masterclass session. So you may recall some of this information. The nature of this project was that we sought to implement peer services to help people who were experiencing homelessness, and we placed the peers in a variety of different settings. So let's kind of look at some of the structure here. So again, the Collective Impact Project, we had a 3-year grant timeline, which was very valuable to have that much time in order to, to start the project. For one, we actually had a 1-year startup period to launch the project, which allowed us to form a coalition of community stakeholders to identify peer navigators. That we use the term peer navigators for this project. It allowed us to identify them to be hired, allowed us to get agencies on board in which the peers would be placed. And so again, one of the things that we did was to create a coalition of community stakeholders. And these were a variety of different experts on some of the topics that were important to the project, such as housing placements and resources, other types of community services and resources that people in this setting would require, BHWP was, of course, part of this coalition. The Colorado Mental Wellness Network, which appeared in the library project, served in this capacity as well, helping the peer navigators with sustaining their recovery and so forth. We also had the Metro Denver Homeless Initiative as partners in the project, who had a lot of specific resources around homeless or around home placement. We had social workers involved. We had different presenters trying to bring the peer navigators up to speed on topics of interest. And so the peer navigators were placed in a variety of different settings, as you can see at the bottom there. We had peers who were placed in primary healthcare settings. These were lower cost or Medicaid serving environments. And we also had peers that were placed in more community service hubs that provided all different types of services, such as professional development and resource identification and job support, things of that nature. We also had some peer navigator in more of a community outreach / housing environment. So a lot of different places. So there was some variability in where the peer navigators were placed, but we did experience good successes in all these different places. Also during the startup period, we thought very carefully about the different objectives that we would have, the roles that the peers would play. We did think, of course, about which of these sites would be most appropriate for the peers. And we also developed coalition-led trainings and oversight for the peer navigators. So the peers received bi-monthly education. They also had a community of practice in which they came together to talk about issues and concerns and successes as well. We had the peer liaison role created, and this was an individual who also had the experience of being homeless previously, as the peer navigators did, but who was even further along in her recovery and was very well equipped to understand and assist the peers with challenges and concerns as they came up. And so let's talk a little bit more about the role of the peer navigators in this project. They were placed under site supervisors, and we found that the site supervisor role was very important. It helped to carve out exactly what the peers would be doing. It helped to avoid slipping into beyond the scope of their work. It helped to connect the peer navigators to myself and the team at BHWP. And so that role was very important. And also through the coalition, we identified 4 key peer navigator job focuses or activities. So the peers were designed to provide education to the clients they serve. So this education was about 4 key chronic diseases that we also chose to focus on in this project. You can see those 4 diseases below: cancer, heart disease, diabetes, and COPD / emphysema. So they provided education about those different diseases. And a lot of the peers took it upon themselves to learn some of the basics about these diseases, and therefore were able to even go beyond and help the clients that they serve further. Another peer activity was role modeling, simply being kind of a beacon of hope to the people that they were serving, showing how far along they were in their recovery and demonstrating just how possible that type of recovery is. They were also advocates for the people that they served. At one point, the peer navigators even presented to the Colorado Department of Public Health and Environment, and really changed the understanding of a lot of people in that setting, and really helped to further this movement. They were also involved in navigation to different types of services, both within the organizations that they worked with and the community at large. So a lot of value there. And finally, they also were trained to help screen the clients that they served for housing status. And so through this process, a fair number of people actually were able to secure temporary and/or permanent housing. And so while we weren't able to track this information, we did see a lot of progress made there. So let's look at some project outcomes. And as the grant manager of this project, I saw, in addition to these measurable results, I saw great growth in the peers and their abilities and their the quality of their work and the forms that they submitted. They became more and more skilled in their abilities to help people, to identify resources and refer people to resources. And so the project just continued to improve and improve over time. And over the two, a little over, we had, as you recall, we had a 3-year window. The actual client-facing work was a little over 2 years of that time. And in that time, we saw 1,071 clients be supported by the peer navigators. And of those, 823 were screened for chronic diseases. So showing that a lot of these encounters really were encounters of value. They weren't simply brief or limited. And we also saw 429 people referred to healthcare services. So another big benefit of this project, actually getting people to trust the healthcare system and to go and secure services. And ultimately, the sites and the peer navigators did demonstrate the value of peer-based work through these results, and also due to the fact that several of the peer navigators were able to continue to succeed in this field after the end of the project. So several of the peer navigators continued in these roles. Some of them today actually have full-time roles in this capacity and have continued to grow in this field. And so that is another example of the success of the project. And you can see on the right there, we do have a project playbook for free download on our website with more information and takeaways. Okay, let's, with those 3 case studies in place, let's look at some of the challenges and rewards of peer specialist work. I want to point out that boundaries are critical to successful peer work. So agencies and staff must understand what the peer role entails and what it does not. So everyone really needs to be on board and be mindful of the peer role. And so it is important to train staff about what those individuals are designed to do. And client boundaries also are critical for peers. Peer burnout can occur if they are, going too far above and beyond their role and trying to support people outside the scope of their work. That can be a challenge, and it's something that peers have to be mindful of, as they do want to help the people that they serve, but really need to be, there's only so much that a person can do. And so peer work does need a lot of support and structure, planning and meetings to focus on that role, on the challenges that come up and that we perceive to be existing in the future, and having plenty of time for self-care is important. And peers need time allotted for these practices. And so as we saw in the Denver Public Library, time was set aside for that. Likewise, in the Collective Impact Project, peers, as part of their work, were required to attend those education sessions and those group meetings as well. Let's look at some of the rewards of peer work, and some of these are, of course, obvious. Helping clients to succeed really is the ultimate reward for the peers and for the agencies that support them. Many peers do view this as an opportunity to give back. Many of these individuals, were supported in their own recovery in the past, perhaps by, prior peers, and they really do value the opportunity to return this favor and to inspire others and to help them, make improvements in their life. And so the ability to support and see that real change in people's lives is really rewarding, particularly when you can have reoccurring encounters with clients, as we saw in both of those projects I just mentioned. Some other rewards are, of course, personal and professional development. The peer role and structure is helpful to peers themselves in maintaining recovery, as we saw in an earlier slide. And ultimately, this work can open doors to not only do peers get new trainings and skills and education through doing this work, but can really go down new career paths as well. And so some of the key takeaways here, organizations really must be ready for peer specialists and be prepared to provide the appropriate support. So we need to clearly establish the peer role, as I've noted, and offer structured support. And what else? Some of the things that we saw is that effective peer specialists were those who were best able to access and leverage their own experiences to help others. Of course, they needed to be far along in their recovery and stable in that respect. they were also effective when they celebrated client strengths and resourcefulness and really called that out to the clients and made them aware of that skill set and that value of it. And also effective peer specialists took the time to maintain their own wellness and self-care in order to avoid any sort of relapse or burnout. That, of course, is also a very important part of this work. Okay, let's now try to distill some recommendations for delivering a successful peer-driven service. Let's try to put these together. And here are some guidelines for sustainability. I'll start at the top here. We want to allow time to train healthcare and social service providers on peer-led services and recovery-oriented perspectives. So this is a very important part of this work. Staff need training on how to use peer specialists appropriately, because staff may not initially know how to incorporate peer roles into the workflow, into the agency structure. But over time, staff typically starts to value peer work very highly, as evidenced by the library project and the growth of the impact there, and as one example. It's also important to establish a culture of data early in the process. So evaluation need not be onerous or time-consuming, but continuous evaluation allows stakeholders to monitor the progress that's achieved and to advocate for what a program might need, including along the way. For example, in the Arizona project, nicotine replacement therapy was needed, and this was reported by people in the program, and that helped to assure that that resource continued to be available, whereas otherwise it might not have been perceived as necessary and could have been removed. In the Denver Public Library project, it was learned that more peer specialists were needed, frankly, and so they were able to add those. And so ongoing evaluation helps us to know what's working well, what is not, and also to get credit and more funding for work to carry it into the future. And so we need to think through evaluation, measurable outcomes prior to starting a program and figuring out what we can measure and what does success look like. And we also want to implement flexible programs and workflows when possible. And so all three of the programs I've highlighted described benefited from some flexibility, including in the work that was done, the focus of the work, the data that was collected, and so forth. And the Arizona project, for example, the flexible dimensions program helped, where the different groups were run with different frequencies, and also having peers run the group assisted with making it more feasible and manageable, as opposed to having outside facilitators come in, for example. Likewise, the collective impact project demonstrated that we could be flexible in the types of organizations that participated, and we could even have some thoughtful shift in the scope of the peer work over time as they became more skilled in their work. Also, we want to plan a professionally supportive infrastructure. So this is a very important aspect of peer-driven programs, and I really can't emphasize it enough. Peer roles need robust training. They need continuing education and continued professional development in order to keep advancing. They do need intensive supervision, as I've described. Having some collaboration or a community of practice to help sustain peer recovery and growth can be important, and as is leaving time for our self-care. And all these supports really are important. And we want to strive to create permanently funded peer positions or other pathways to permanent employment. So for example, peers at the Denver Public Library and in the Collective Impact Project, they were concerned about ongoing funding for positions and the positions ending. And so job security was of vital importance. It's also important in order to retain peers to have this in place. And it's important to occupational well-being as well. The Denver Peer Library Project, the peers actually created a presentation to the Mayor's Chief of Staff and Budget Office, and this did lead to 6 city-funded peer positions at 30 hours per week being formalized. So that was a major success. Similarly, as I've noted at the end of the Collective Impact Project, we focused on career development, resume building, interviewing, job searching, and as a result, many of the peer navigators did find employment after the conclusion of that project. And so as we move towards the end, now that we've reviewed the general peer specialist movement, consider these projects and have discussed the takeaways and guidance, I want to look forward. So in this final section, next steps, I I want to introduce some things to consider in implementing successful peer-led services at your own agency. And let's begin our focus on next steps with a review of your Jamboard responses from our masterclass. You'll recall that in this room, you're asked this question on the left: what role could peer specialists or lay providers play in addressing tobacco use or cessation disparities at your agency? And as you can see, several of these themes emerged, and even some initial thoughts about specifically how peers could support your agencies. And so to kind of highlight these again, peers could function as role models and advocates for the clients they serve and the peer movement overall, demonstrating accountability and guidance and spreading the word about their work and the benefits of tobacco cessation. Peers were also identified as being valuable and practical agency work too, serving as a connection between the community and clients and the agency, as well as rendering valuable services for the agency itself. And moreover, services that might not otherwise be effective at an agency. And aiding collaboration and the sharing of wisdom externally and internally were brought up too. Finally, the unique nature of the peer role to establish trust and a common bond between peer specialists and their clients was repeatedly recognized as a valuable asset. And you can see lots of great thoughts there. And in summary, all of you suggested that your agencies could effectively leverage peer specialists and their lived experience to reach previously underserved populations and clients. Okay, in preparing for peer-led services, it's very important that agencies do plan ahead and carefully prepare for the initiation of the peer-led services. And so a lot of thought is needed in the specifics of peer-led services, and including having a clearly stated rationale for the peer program. This rationale, this information serves as a guide for the initiative, and articulating these details ahead of time really helps to keep all members of the organization on the same page and invested. And perhaps the most important step of all is to carefully define the scope of the peer role or roles that are to be created. It's critical, again, that the supervisors of the peers understand and support their role and help make sure that peers stay within the scope of that role. Naturally, the peers themselves must understand what their role entails too, and what it does not, again. But it's also important that all staff members have some understanding of the role too. Identifying sustainable, hopefully, funding for peer programs is an important step to consider from the beginning too. The sudden loss of a peer position can be damaging to the peers themselves and also to the trust and the connection that they may have established within the community. And while identifying clear long-term funding can be difficult, and it may be necessary to launch a program without this type of protection, it is the best practice to establish this ahead of time, or at least plans to pursue this, I would say. And finally, peer roles are more successful when structured within existing workflows. This process helps to make the peer role more effective and sustainable, and can maximize their community impact. And that last bullet point there, peer support champions, are individuals who explicitly empower and support peer work. And these people can help to further peer services via advocacy, identifying resources for the peers, and providing direct support to the peers themselves and helping with their ongoing recovery. And let's talk about training peers for success now. So once an organization has taken the necessary steps to prepare for peer-led services and hired a peer into their role, thoughtful onboarding and training can equip that individual to succeed in their new position. As a reminder from earlier in this presentation, I do want to reiterate that peers should be sufficiently advanced in their recovery prior to being hired. This aspect's really imperative to their success. And so here are some basic strategies about how to effectively train peers. You can have them shadow several team members to learn how your organization and its members function. You can ask them to attend both organization-wide meetings and specialized or department-specific meetings. And this process can help them feel more included as a member of the team and will leave them better informed about the organization as well. Specialized training, particular to the role they will play, is very important too. For example, in this context of tobacco cessation, peers might be trained to be tobacco treatment specialists or to run a tobacco-free group, perhaps. And offering continuing education opportunities can enhance the development and advancement of peers within your agency. And so all in all, training makes for more effective peers while furthering the peer movement and its legitimacy and supporting its legitimacy, and also can help decrease burnout and turnover. Okay, so sustaining peer services. So looking less from a programmatic perspective here. Well, we've looked at sustaining peer positions from a programmatic perspective, but now I want to also look at sustaining peers themselves and peer roles as well. And so again, the role of the peer supervisor is critical, and peer roles may benefit from close supervision and guidance, particularly in the beginning as peers are getting oriented and started. Organizations should offer full benefits, livable wages, and professional development opportunities, again, to legitimize the peer role and movement, and to retain talented peers who really can impact an organization's reach, influence, and positively impact their finances too. These roles can open a whole new community to that agency. As noted earlier, the maintenance of boundaries is critical, and supervisors and organizations really do need to be mindful of role drift and assure that peers continue to do the work that they were hired to do. We need to make sure that, barring a lot of experience and development, we want peers to be doing the work that they were hired to do, at least initially. And so as a final practical step to help everyone get started, I highly recommend that you download BHWP's Dimensions Peer Support Program Toolkit. It's available for free on our website at that link that you can see here. It's a very comprehensive and detailed document. It contains numerous resources and a lot of practical thoughts about successfully implementing peer specialist roles and all the different topics involved. So it's very extensive, goes beyond what I've been able to cover in this webinar, and really can provide more or less a step-by-step playbook for how to get started and how to launch peer work. Okay, so in closing, I hope that this webinar has inspired you and your agency to look more closely at peer specialist roles and to ultimately move forward toward adding these positions to your organization. So thank you very much for viewing this webinar, and I wish you luck successfully implementing peer roles within your agency.